Copyright 2012, APIC Productions. Welcome to the continuation of the Oncology Certificate course. This lecture series is going to focus on the targeted therapies used in the treatment of cancer. The first part of this lecture is going to talk about the monoclonal antibodies used in the treatment of cancer. And then we're going to follow up with the treatment with the small molecule inhibitors such as the proteasome inhibitor and protein kinase inhibitors used in the treatment of cancer. So our goals out of this lecture series is that we understand the mechanism of action of your monoclonal antibodies, understand its uses, and then especially the side effect profile, because again, it's different than your traditional chemotherapy drugs used. It was in the 1900s that the term magic bullets were first coined, or was first coined. It was determined that maybe we could look at the genetic profile of a disease and actually develop drugs that would target that disease. Such is the case in cancer. It wasn't until really the mid-1970s that the first technique for the development or purification of monoclonal antibodies was first described. And then we follow up with, in the 1980s, the development of OKT3, miromanab, used in the treatment of transplant rejection. And then in the 1997 was really when we first introduced rituximab, or the first monoclonal antibody used in the treatment of cancer, and it was FDA approved for the treatment of non-Hodgkin's lymphoma. So when we think about monoclonal antibodies, I think you have to keep in mind that the mechanism of action is different, as well as the side effect profile. Here you will see a slide, and it can list not only a little bit about how the small molecule inhibitors work, but also where your monoclonal antibodies target. And as you can see, remember, these are targeting really specific either receptors or they're inhibiting ligands in circulation. And so that's really what we're thinking about when we think about monoclonal antibodies. We're not expecting the traditional effects such as inhibiting DNA replication or inhibiting mitotic division. What we're looking at is binding to a receptor as well as binding to receptor ligands in circulation. So let's just jump into the monoclonal antibodies. Here you're going to see a table, and this table is really a summary, and I selected these monoclonal antibodies used in the treatment of cancer. You will see that gemtuzumab, or Mylotarg, is grayed out for right now. It was FDA pulled it from the market. However, there's a lot of literature coming out of ASH that suggests that maybe gemtuzumab does have a specific indication maybe for select patients with AML. So what we're going to do in this series is we're going to go through these monoclonal antibodies, and we're going to discuss their mechanism of action, their indications, as well as the selected side effect profile. So things that you should be aware of as a healthcare provider when you are administering these medications. I am assuming that you guys will review or recall some of the nomenclature used in monoclonal antibodies. Just as a reminder, remember, you look at the last, the middle section when you're thinking about the chimera, if it's chimeric or not. And remember, the MAB section tells you at the end that it's a monoclonal antibody. For instance, miromanab, the O in it means that it's derived from a mouse, so it's murine derived. Cetuximab, the XI, would be a chimeric medication. ZU, like trastuzumab, would be a humanized one. And then panitumumab would be a fully human monoclonal antibody here. So just as a reminder, this is really what we're thinking about when we think about chimerism. You can see that if it's murine derived, it's about 35% derived from a mouse. When we look at human, we're thinking about 100%, it is 100% from a human. I point that out because remember that a lot of times your hypersensitivity reactions depend on the type of derivative or product that it's derived from. That's not necessarily the case. When we look at panitumumab, we clearly see that there are infusion reactions, even though it is a fully human monoclonal antibody. But I think, as in general, this is important to realize that, when you have either a murine-derived one or a chimeric one, that we have to be thinking about side effect profiles such as infusion reactions. So as a reminder, we look at how monoclonal antibodies work, and I think there are really a couple ways that we look at. The first thing we look at is, does it directly inhibit or enhance cytotoxic or cell death? This may work in various mechanisms, such as inducing apoptosis, or it may interfere again with the ligand receptor binding. Indirect is really one of the major mechanisms for monoclonal antibodies. There's complement-dependent cytotoxicity and antibody-dependent cell-mediated cytotoxicity. So those are really the two things we think about with the mechanism of action with your monoclonal antibodies. All right, and again, as a summary, before we just dive into the monoclonal antibodies out on the market, remember that all of these really possess the capability or potential to have severe infusion reactions with it. Some are going to be greater than the others. A lot of times we're going to do pre-medications with those. And when I say pre-medications, we're trying to prevent the side effects of hypersensitivity reactions. So keep in mind the drugs we typically use would be acetaminophen, diphenhydramine. You might have some meperidine on board for rigors. You may have a corticosteroid on as well. So keep that in mind. A lot of times these medications may require a code cart in the vicinity of the area, just in case that they have an acute hypersensitivity reaction. All right, so we're going to start with rituximab, and we're going to go through all of these monoclonal antibodies that I consider cell surface glycoprotein monoclonal antibodies. So rituximab, again, was the first one that came to the market really for the treatment of a specific oncologic disorder, and that disorder was non-Hodgkin's lymphoma, particularly diffuse large B-cell non-Hodgkin's lymphoma. Rituximab is the generic name. Rituxan is the brand name, and specifically it binds to the CD20 positive receptor or CD20 receptor on B cells. And when you look at diffuse large B-cell lymphoma, those B cells are going to have CD20 on the receptors. So rituximab is very specific for this. There are some other indications that have been approved after or since 1997. This includes chronic lymphocytic leukemia, CLL, where we actually have to use much higher doses to get pretty good cytotoxic or antibody-dependent cytotoxicity. So we do higher doses of rituximab in CLL. And we also see it used in some autoimmune diseases, such as rheumatoid arthritis. There's literature looking at Crohn's, there's literature looking at multiple sclerosis, and so there's a lot of other disorders that they're looking at for use of rituximab. I think the thing you have to think about with rituximab is the dosing of it. First of all, the first infusion takes several hours, maybe 6, if not 8 hours. And what you do is you start the infusion at a very slow rate, and then you can titrate or increase the rate as the infusion goes on, as long as you don't have any hypersensitivity reactions. Interestingly enough, it's the first time that you receive rituximab that we often see the worst reactions. And so this is sort of counterintuitive, where we usually expect you to be sensitized or have been exposed to a medication. But with rituximab, it's the first infusion that has the worst reactions with it. So the toxicities, we think about hypersensitivity reactions. We're always going to premedicate with Tylenol as well as diphenhydramine. There are some significant warnings with rituximab. The first thing you have to consider is the tumor lysis syndrome. And there has been fatalities due to the tumor lysis syndrome with it. So remember, rituximab is used in high burden cancers. And when I say high burden cancers, I mean tumors that are really widespread throughout the body, such as leukemias and lymphomas. Remember that with tumor lysis syndrome, we see an increase of potassium, we see an increase in uric acid, we see an increase in phosphate, and a decrease in calcium. Well, when you have massive cell lysis going on after administration of rituximab, you can have severe electrolyte or abnormalities that can lead to death. And so you as a pharmacist or healthcare provider needs to make sure that you're aware of this and have the appropriate medications on board, such as allopurinol for uric acid. Make sure you know what to do if if you need a phosphate binder. Know what to do if you need treatment for hyperkalemia. And so that's really important. That is one of the black box warnings for rituximab. The other warning that is out there is reactivation of hepatitis B as well as CMV. Now, interestingly, there has been cases of reactivation of Hep B leading to fulminant hepatitis and death. And so again, this is something that you're going to keep in mind. You're probably going to want to make sure you appropriately identify the correct patients so that you don't worry about reactivation of hepatitis B. So those are really the two big warnings that we see with rituximab. We see tumor lysis syndrome as well as reactivation of hepatitis B as well as cytomegalovirus. Again, rituximab is really one of the big workhorses for oncology, especially when we think about either CLL or non-Hodgkin's lymphoma, especially when we think about that either diffuse large B-cell lymphoma or follicular cell lymphoma. All right, the next two medications I have up here are not used as often as rituximab. However, they both target CD20 on B cells. So the first one I put up here is Zevalin, and this is really an agent that's limited because of its use, because you have to use either radioactive indium-111 or yttrium-90. And so it is that component of it, the radioactivity of those, either the yttrium or the indium, that lead to cellular damage. So indications, again, non-Hodgkin's lymphoma. It's not used as frequently as rituximab. It does not have the studies out there as much as rituximab. The big toxicity profile is significant pancytopenia, including significant thrombocytopenia. So you are going to want to make sure you monitor your patients and have them understand that they are going to be neutropenic or thrombocytopenic for some time. And that's really different than what we would see with rituximab. We don't necessarily expect that in most patients. Tozotumumab or Bexar is another agent used. Again, very similar in that same class as rituximab and Zevalin. Bexar, again, targets CD20, and this time it's linked to iodide 131. So again, another radioactive drug that is then linked to cytotoxic or cell death. It's, again, use is really limited. There are clinical studies. Most of them are suggesting that if they would fail rituximab, this may be an option. Or you would just put a patient on a clinical trial to receive this agent. You as a healthcare provider need to understand that you must give a thyroprotective agent, and this is typically potassium iodide drops, and we start usually 1 day prior to them receiving Bexar. Again, because it's linked to iodide 131, we want to make sure we preserve thyroid function. So that's important for you as a pharmacist. Again, we're going to make sure that we pre-medicate when they receive this medication. And very similar to Zevalin, we're going to see prolonged pancytopenia. And as I put on the slide here, the nadir is 4 to 7 weeks. That's pretty significant when we think about a monoclonal antibody. most of our monoclonal antibodies don't prolong neutropenia or pancytopenia for that long. All right, ofatumumab, or Arzerra, was approved within the last couple years. And some would say maybe this is like a second generation type of CD20 positive monoclonal antibody. Others will say, you know, this is the superpower when we're thinking about CD20 positive diseases. What I can say is it's still really used as a second line agent compared to rituximab for the most part. It does have the indication for chronic lymphocytic leukemia, and there are studies looking at its use in non-Hodgkin's lymphoma. From the patients that I've seen receive Arzerra or ofatumumab, something that's very similar to Rituxan is a prolonged infusion duration. So many of these patients are taking 8 hours to receive ofatumumab. And one of the reasons is because we can't increase that rate very quickly because they do tend to have hypersensitivity reactions. And so the rate is often very slow, and these patients are in the chair, in the cancer chair, or the center chair for some time here. Very similar indications or warnings such as reactivation of hepatitis B. You do have prolonged thrombocytopenia and neutropenia with it. And you can see here 70% report severe infections. So the side effect profile is a little bit more severe compared to rituximab. All right, moving out of the CD20 agents, I'm going to just put a slide up here about gemtuzumab. I think you as a healthcare provider need to remember or know about gemtuzumab in case patients ask you. And like I said, it was, there are some studies looking at its use. So gemtuzumab was approved in the early 2000s, and its brand name is Mylotarg. Gemtuzumab binds to the CD33 antigen on leukemia cells. And CD33 is often found in acute myelogenous leukemia. So gemtuzumab uzogamicin received the indication for the treatment of AML. What's interesting about it is actually they received the indication if you were greater than the age of 60 for the treatment of AML, and if you didn't really have any other options out there. What really has come out within the last year, which provoked the FDA to remove it from the market, is that clinical trials, really when you looked at the results, didn't show an improvement in survival when you used Mylotarg. So the FDA did pull it from the market, saying there was no benefit. Again, information coming out of the 2011 American Society of Hematology suggests that maybe there are select patients that would benefit from gemtuzumab. And I tell you this because we might see this back on the market here in the next couple of years. As a pharmacist, you would want to know about gemtuzumab. It must be prepared in a dark room. And so oftentimes if you're administering or preparing this medication, you're going to shut off the rooms in your IV room, keep a little bit of light on just to make sure you can prepare it, but it is sensitive to light. And so that's something unique about gemtuzumab. All right, alemtuzumab, known as Campath, binds to the CD52 antigen on CLL cells. And so it actually targets the lymphocytes on CLL, and thus has the indication for chronic lymphocytic leukemia. Alemtuzumab can be given either IV, or a lot of literature is coming out about sub-Q use. If it's given IV, typically it's 3 times a week. The same with sub-Q route is looking to have very similar efficacy. And that's really making alemtuzumab a much more desirable option now for the treatment of CLL. We do continue to pre-medicate with acetaminophen and Benadryl, and we do keep a corticosteroid on board in case patients have a severe reaction. I think something unique about alemtuzumab is, again, prolonged immunosuppression. These patients go, 4, 6, 8 weeks with the nadir. And what really is, I guess, the concern is that it puts them at an increased risk for infections. We do see the increased risk of PCP as well as HSV and CMV reactivation. So with that in mind, we'll often give acyclovir for HSV. We'll put them on Bactrim twice weekly for PCP prophylaxis. And keep in mind that, if they do have a reactivation of CMV, we're going to go straight to ganciclovir for the treatment of cytomegalovirus. So that's the big thing with alemtuzumab. All right, so just as a review, we covered rituximab, Bexar, Zevalin, ofatumumab, which are CD20 antigens. We also covered then alemtuzumab, which is CD52, and I mentioned gemtuzumab for CD33. Let's move on to really one of the blockbuster drugs out there, bevacizumab. And before I just jump into bevacizumab, I'm going to just go back here, regress a little bit, and tell you about its mechanism of action. So bevacizumab is it was the first drug as a monoclonal antibody in the class known as anti-angiogenesis agents. And why this is important is remember that when we have angiogenesis or tumor growth, we have to have blood vessels. And these blood vessels really support the tumor. And as the tumor grows, we increase our angiogenesis. One receptor or ligand that is known to be involved in angiogenesis, it's VEGF, the vascular endothelial growth factor receptor. So VEGF is involved in angiogenesis. I point this out because we're going to see not only bevacizumab used as a target for this, but a lot of our small molecule inhibitors such as sunitinib or pazopanib, they're going to target VEGF as well. So our goal here is really to inhibit angiogenesis so that the tumor does not grow or cannot grow any larger. So that's where bevacizumab or Avastin comes in. It was approved in the early 2000s, and what it does, unlike the other monoclonal antibodies that we just discussed, it actually binds to the VEGF in circulation. So it binds to it in circulation so that it can never bind to the receptor. Unlike the other monoclonal antibodies that actually bind to the receptor on the cell surface receptor. Here, this is binding to the ligand in circulation. Bevacizumab has a pretty extensive indication profile. It was first approved for the treatment of colon cancer. And when I say treatment of colon cancer, remember that it's really only approved for the metastatic treatment of colon cancer. It doesn't have the indication for adjuvant, the treatment in the adjuvant setting for colon cancer. In addition, it does have non-small cell lung cancer and certain subtypes. We think about renal cell carcinoma, and it is one of the treatments that may be preferred in RCC, and then glioblastoma. All right, bevacizumab, remember, did create quite the controversy when the FDA withdrew the indication for breast cancer. This is really based on the trials coming out that, again, suggest no improvement in overall survival. And I think that is a whole different topic that we could discuss here is the endpoints used in most of our cancer trials. And most of our cancer trials are not using overall survival as the primary endpoint. Instead, they're looking at maybe progression-free survival or maybe side effect profile. So again, bevacizumab does not currently have the indication for the treatment of breast cancer, but it does have all of those other cancers out there. Similar to all your other monoclonal antibodies, it's given IV, and IV formulation maybe every 2 weeks or maybe every 3 weeks, depending on some of the cancers that we're looking at. Toxicity profile is pretty similar to a lot of the other anti-angiogenesis agents. So what we think about is delayed wound healing. This is important, especially for patients after surgery. And when we think about patients coming out of surgery, you're going to want to wait at least probably 4, if not 6 weeks to start bevacizumab after surgery. We do see increased risk of GI perforations with bevacizumab, as well as many of our other anti-angiogenesis agents. We do see an increased risk of hypertension, thrombotic events, proteinuria. That's going to warrant monitoring. And so you're going to want to make sure that you look at your urine protein samples and collect and monitor the protein. And if you have an increase in protein in the urine, you're probably going to either discontinue it or hold therapy here. So bevacizumab has a lot of side effect associated with it, but for the most part, again, it's one of the workhorses, I would say, in the treatment of cancer. All right, there's just a couple other monoclonal antibodies that I want to discuss. We're going to move in to the epidermal growth factor receptor monoclonal antibodies, known as EGFR monoclonal antibodies. And there's a couple out there in this class. The first one we're going to talk about is cetuximab, and its brand name is Erbitux. It was approved within the right around the same time as Avastin was for colon cancer. And Erbitux binds to the epidermal growth factor receptor. And what that does is then it inhibits EGFR binding and signal transduction. And so we don't see then really the cell cycle cascade is inhibited. The indications are for colon cancer, and again, it is used in the treatment of metastatic colon cancer, not in the adjuvant setting. It also has the new indication that it must be given in patients without the KRAS mutation. And we'll talk about KRAS when we talked about colon cancer, but what's important about people with KRAS mutations means that they have typically they have more advanced disease, and so that mutation occurs later down the road with colon cancer. But those patients do not respond to cetuximab or any of your EGFR monoclonal antibodies. In addition to colon cancer, it does have the indication for head and neck cancers. For the dosing of cetuximab, I do point out that the package insert suggests staining for the EGFR. In practice, that is not done. What they have found is studies suggest that regardless of how sensitive or your EGFR is positive, that patients do respond. And so there appears to be no correlation between EGFR and the response with cetuximab. So really the one test that you do want to make sure that you perform is the KRAS and checking for the KRAS mutation. Similar to your other monoclonal antibodies, we're going to start slow with cetuximab and then increase the titration upward as the infusion goes on. Our toxicities, of course, we're going to have, it's a chimeric one, so we're going to worry about infusion reactions. But I think the big toxicity you're going to keep in mind, because it's an epidermal growth factor receptor inhibitor, is the acne-like rash. Now, people may say acneiform rash, acne rash, and really when you really look at the type of rash that occurs, it's not acne. And so here's a picture of a patient with a cetuximab rash. It typically starts within the first week after receiving an epidermal growth factor receptor inhibitor. Studies suggest that there is, again, it's not acne, there's no bacteria found when we think about this acne, but it's because we're disrupting the cell cycle of the epidermis that we are causing this acne-like rash. Treatment for the acne rash, acne-like rash, really consists of good moisturization, using good moisturizers, avoiding the sun, and then good skin hygiene. We may see antibiotics used, such as clindamycin or maybe a tetracycline. Oftentimes those are used either to prevent secondary bacterial infections, but a lot of those agents do have anti-inflammatory properties, which can be beneficial when we're talking about this rash. I know it is a big concern for patients, especially when you look at quality of life and the effect it has on a patient. However, I think you must counsel the patient that people that experience this rash tend to have prolonged survival and have the best outcomes with cetuximab. And so I know of physicians that actually titrate so that they see this rash so they can ensure their patients are going to have the optimal outcome with cetuximab or your EGFR inhibitors. Panitumumab or Vectibix was the second EGFR inhibitor approved for the treatment of colon cancer. And this is really usually reserved as maybe one of the last agents used for colon cancer. The clinical study that Amgen received approval on was looking at the use of panitumumab compared to best supportive care for patients with end-stage colon cancer. And so this again is very similar to cetuximab. Even though it is a fully human monoclonal antibody, we do see that there are hypersensitivity reactions with panitumumab. And again, similar to your cetuximab, you're going to want to make sure that you check for a KRAS mutation to know if they are going to respond or not to this medication. All right, and then a couple last monoclonal antibodies. I think many of you are probably wondering, when am I going to talk about trastuzumab? And again, trastuzumab or Herceptin binds to the HER2/neu receptor. HER2/neu is really synonymous with epidermal growth factor receptor. HER2 means epidermal growth factor receptor 2. And so Herceptin is used in the treatment of breast cancer and specifically patients that overexpress HER2/neu, which is about 25% or so of patients with breast cancer. How it works is it binds to and leads to antibody-dependent cellular cytotoxicity. And so that's where trastuzumab fits in. Dosing is similar to the other monoclonal antibodies. We're going to start slow and then increase with following weeks. Keep in mind that there is significant some cardiotoxicity associated with it, dose-limiting cardiotoxicity with it. And so keep that in mind, because that reason is we don't give it at the exact same time when we're giving doxorubicin or anthracyclines. We're going to want to make sure that we spread that out, because we see an increased risk of cardiotoxicity when those two are given simultaneously. So besides cardiotoxicity, we do see infusion reactions with it, but for the most part it's fairly well tolerated agent. Ipilimumab, Yervoy, was approved last in 2011, about in March of 2011, and it was approved for the treatment of metastatic malignant melanoma. Ipilimumab it really is sort of a unique medication. You can see that it binds to binds to the cytotoxic T lymphocyte associated antigen 4, so CTLA4. And what that really does in the end is it increases T cell production. And when we see an increase in T cell production, there's a lot of people or a lot of literature that suggests that maybe we can overcome malignant melanoma, and there must be some type of immune dysfunction or dysregulation going on with melanoma. And so that's the whole goal of ipilimumab. Ipilimumab, interestingly, was the first agent to show an increase in overall survival for the treatment of melanoma. And so this really was one of those agents that has clearly impacted malignant melanoma. Ipilimumab is an IV medication, and it's given every 3 weeks for 4 doses. And the toxicities, I think you have to point out that there's severe and often and maybe fatal enterocolitis. And so they really make sure that you as a provider are doing appropriate monitoring and counseling those patients to make sure that they don't have severe diarrhea or abdominal pain. If you do experience a patient that's coming into you for enterocolitis, make sure you start high-dose corticosteroids immediately on this patient, because again, this can be a severe and fatal side effect. All right, so that is really a summary of some of the main monoclonal antibodies used on the, for the treatment of cancer. I think we covered pretty much the big ones used in this. Keep in mind that they all target different receptors. Some actually target the ligand in circulation, such as bevacizumab. In the end, many of them have infusion reactions, but keep in mind some of those ones that are really related to the medication, such as the EGFR inhibitors causing an acne-like rash. We're thinking about prolonged neutropenia and a prolonged immunosuppression, say with alemtuzumab, which is going to require usually some type of antibacterial or antimicrobial prophylaxis. So that's the first part of our two-part series on targeted therapies. The next section, we'll talk about small molecule inhibitors. Copyright 2012, APIC Productions.